You have a lumbar disc herniation, and at some point in this journey, someone may tell you that surgery is the right next step. Maybe you already heard it. Maybe you're trying to decide if you're there yet. Maybe you came to this video specifically because you want to understand what surgery actually means before you agree to it. I'm a spine surgeon. This is the conversation I have with patients before we schedule anything. And I've always believed that a patient who understands what they're agreeing to, what the operation involves, what the recovery looks like, and what the evidence says about outcomes makes a better surgical candidate and has a much better experience. So that's what this video is. It's not a sales pitch for surgery. It's an honest explanation of what it is, when it's warranted, and what you should realistically expect. This is the fourth and final video in the lumbar disc herniation series. If you've watched video 1, 2, and 3, you already understand the anatomy, the symptoms, and the full landscape of conservative care. This video is for the patient who's either been told surgery is the recommendation or a patient who just wants to understand it before that conversation even happens. First, surgical indications. The specific clinical criteria that makes surgery the appropriate next step, and the difference between an absolute and a relative indication. Second, the operation itself. What a lumbar microdiscectomy actually involves, what surgeons are doing and why, and the difference between a discectomy and other procedures you may have heard about. Third, recovery, what the first days, weeks, and months look like and how to think about realistic expectations. And fourth, outcomes, what the data actually shows about surgical results for disc herniation and the honest picture of what surgery can and cannot fix. I'm Dr. Omar Ramos, a spine surgeon at Twin City Spine Center in Minneapolis. I perform lumbar discectomies regularly as part of my spine practice. The framework I'm going to walk you through is the same framework I use when I'm sitting across from a patient deciding whether surgery is the right call for them. Let's start with the most important question. When is surgery actually warranted? In surgery, we distinguish between absolute indications and relative indications. An absolute indication means surgery is required. The clinical situation is urgent enough that non-surgical management is not an acceptable alternative. A relative indication means that surgery is a reasonable option and the decision involves weighing the patient's symptoms, their response to conservative care, and their goals. The clearest absolute indication for lumbar disc herniation surgery is cauda equina syndrome. I covered the red flag symptoms in video 2, bladder dysfunction, bowel dysfunction, saddle anesthesia, progressive bilateral leg weakness. When these symptoms are present and imaging confirms significant cauda equina compression, this is a surgical emergency. The window for intervention matters. Delayed decompression in cauda equina syndrome is associated with a worse neurological outcome. This is not a situation for a second opinion or a trial of conservative care. This is an operating room situation. The second absolute indication is progressive neurological deficit, specifically a motor deficit that is worsening despite appropriate management. A patient with an L5 radiculopathy who has intact strength is in a much different situation than a patient whose foot drop is progressing and getting worse week over week. When the neurologic examination shows measurable deterioration, not just pain but function, that's when the conversation changes. The relative indications are where most surgical decisions live and where the most nuanced conversation happens because here surgery is an option, but it's also an option not to do surgery. The standard framework for relative surgical indication in lumbar disc herniation is this: a patient with significant radiculopathy, imaging that shows a herniation corresponding to their symptoms, and examination who has failed an adequate trial of conservative care, typically 6 weeks minimum, often longer, is a reasonable surgical candidate. Let me unpack what failed conservative care means because this phrase gets used loosely. It means that the patient has had structured, appropriate conservative management, not just ibuprofen and a few PT appointments, and has not achieved acceptable symptom control. It means the herniation and clinical picture correlate, and it means the patient and physician agree that the current symptom burden justifies the risks of surgery. Duration alone is not the only factor. Quality of life is a legitimate consideration. A patient whose radiculopathy is severe enough to prevent them from working, caring for their family, or sleeping is in a different situation than a patient that is managing symptoms with activity modification only. There is no prize for waiting longer than necessary. Now, let's discuss who tends to do best with surgery. The patients who tend to have the best surgical outcomes are those with a clear single-level herniation that corresponds precisely to their symptoms and examination, predominantly leg pain rather than back pain, and a relative short duration of significant symptoms. The patients where the surgical decision is more complex, those with predominantly back pain and minimal radiculopathy, multi-level disease, where it's less clear which level is actually the primary driver, a long duration of symptoms with possible nerve damage or significant comorbidities that increase the surgical risk. These situations aren't necessarily surgical contraindications, meaning surgery shouldn't happen, but they require a more detailed conversation about realistic expectations. Now that you understand when surgery enters the picture, let me show you what the operation actually involves. Because in my experience, most patients' anxiety about surgery isn't just whether they need it or not, it's about not knowing what's going to happen to them. So let's fix that. The most common surgical procedure for lumbar disc herniation with radiculopathy is a lumbar microdiscectomy. This is a minimally invasive procedure designed to remove the portion of disc that is pinching that nerve. I want to be clear about what this operation is and isn't. A microdiscectomy removes the herniated fragment, the material that is pressing on the nerve. It doesn't remove the entire disc. It doesn't fuse the spine. It does not require placing screws or any other instrumentation. For the vast majority of patients with a lumbar disc herniation and radiculopathy, this is the operation that they need. There are some specific scenarios where you need to consider a fusion, but this is not for the majority of patients. Let me walk you through the operation step by step, because understanding it makes it significantly less frightening. Patients are positioned face down on the operating table with their low back gently flexed to open up the interlaminar space. General anesthesia is used, meaning you're fully asleep, and then we make a small incision in the midline of the low back, typically about 1 to 2 centimeters, directly over the affected level. The specific level is confirmed intraoperatively with fluoroscopy, which is a real-time X-ray, to make sure we're operating at exactly the right place. We then use a small 1 to 2 centimeter tube to go through the paraspinal muscles without detaching them from the spine, and then gently expose the lamina. That's the bony arch of the vertebrae. Using the operating microscope or surgical loops for magnification, we then remove some of the ligamentum flavum, which is the ligament that lines the back of the spinal canal, to access the epidural space where the sac with the nerves is. In some cases, a small portion of the lamina is also removed. This is called a hemilaminotomy, not a laminectomy where we remove more bone, just a small amount of bone. Once inside the epidural space, we identify the nerve root that is being displaced by the disc herniation, move it away from the disc herniation gently, and then remove the herniated disc fragment. We then identify the nerve root that had been pinched to confirm that it's fully decompressed. We then close the wound, and the skin incision is typically closed either with absorbable sutures or surgical glue. We don't use any screws. Again, no fusion. Now, you may have questions about fusions or other procedures that you've heard of. Patients often come to the consultation having research procedures they've heard about: lumbar fusion, TLIF, disc replacement. A lumbar discectomy and a lumbar fusion are fundamentally different operations designed for different problems too. A lumbar fusion is designed for spinal instability, where the bones are shifting out of place, also using deformity or degenerative disease causing significant back pain. It involves removing most of the disc material, placing bone graft between the vertebrae, and using hardware, screws and rods, to stabilize that segment. And it is a more extensive operation with a longer recovery, and again, generally used for different diagnoses. As we mentioned before, there are some scenarios where you may need a fusion in the setting of a disc herniation, but it's not the vast majority. For straightforward lumbar disc herniation with radiculopathy in a patient without significant deformity or instability, fusion is generally not indicated. If you have been recommended a fusion for a disc herniation without a clear explanation of why a discectomy alone is insufficient, that is a conversation worth having, and potentially a situation where a second opinion from a spine surgeon may be appropriate. Now, let's talk about what comes after the operation. For most patients, the decision about surgery isn't just, do I need this? It's, what does my life look like for the next 2 or 3 months? Let me give you an honest, realistic picture of recovery. Most lumbar discectomies are performed as outpatient procedures, meaning you get to go home the same day. In the first 24 to 48 hours, most patients notice that their leg pain, the radiculopathy, is significantly improved. This is one of the most gratifying aspects of a successful discectomy. The nerve decompression that happens in the operating room often produces immediate improvement in the leg symptoms. Back pain from the incision and muscle retraction is expected and typically managed with a short course of oral pain medication. Some patients need them for a few days. Some patients don't even need them. This is very patient dependent. Moving walking is encouraged within hours of surgery. The goal from day one is controlled progressive movement. In the first 2 weeks, walking is the primary recommended activity. Short walks multiple times a day, progressively increasing in duration. Most patients can shower within 24 to 48 hours. We do ask patients to avoid getting into pools, bathtubs, lakes, or any other bodies of water until the incision is healed, usually 2 to 3 weeks, to avoid risk of infection. What's restricted in the early weeks: heavy lifting, repetitive bending and twisting at the lumbar spine, and activities that place significant axial load on the disc. These restrictions exist to minimize the risk of reherniation during the early healing period, although they don't completely eliminate it. Most patients are significantly more functional by the end of the second week. For patients in sedentary or desk-based work, return to work in 2 to 4 weeks is very realistic. Patients in more physically demanding occupations, the timeline may be a little longer, typically around 6 weeks. Formal physical therapy typically begins around 4 to 6 weeks postoperatively, once the early healing phase has passed. The goals are core stabilization, motor control, and progressive return to full function. This phase is not optional. Patients who engage seriously with postoperative rehabilitation have a better long-term outcome. By 3 months, most patients who have had a successful microdiscectomy are back to full activity, including exercise, sport, and physically demanding work. One thing worth naming directly: some patients experience a period of nerve recovery that extends beyond the immediate postoperative period. If nerve compression was significant or prolonged, the nerve itself may take weeks to months to fully recover its function, and in some cases, it never returns to fully normal function. Numbness and weakness can persist longer than the pain. This is not a surgical failure. It reflects the biology of the nerve healing, which operates on a slower timeline than soft tissue or bone healing. The last thing I want to cover is outcomes. What does the evidence actually show about how people do after a lumbar discectomy for lumbar radiculopathy? And I want to be honest with you here, because this is the part of the conversation that I think is most often oversimplified in both directions. For the primary symptom that drives most lumbar discectomies, the radiculopathy, the leg pain, the evidence is very strong. Lumbar microdiscectomy is one of the most evidence-supported procedures in spine surgery for this indication. Multiple high-quality trials show that patients who undergo lumbar discectomy for disc herniation with the radiculopathy experience significantly faster and more complete relief of leg pain compared to those that are managed without surgery. At early follow-up, 3 to 6 months, the surgical advantage is very substantial. Here's the honest part: surgery for lumbar disc herniation is very good at relieving the leg pain, much less predictable at relieving back pain. Back pain in the context of a disc herniation has multiple sources: the disc, the facet joints, the paraspinal muscles, the secondary postural adaptations the body makes around a painful disc. So removing the herniated fragment addresses the nerve compression and the leg pain. It may not address all these other potential sources of back pain. This is why the patient profile matters. A patient whose primary complaint is leg pain with some back pain as a secondary symptom is a very different surgical candidate from a patient whose primary complaint is back pain with minimal leg pain. Those patients may not do as well. Something very important to be aware too is reherniation risk, which is the most common complication specific to lumbar discectomy. Is reherniation at the same level? Remember, you have a tear in the annulus, and that tear we cannot really repair. So you'll always have a weakened area there where more material can come out. The literature report rates in the range of 5 to 15% over 5 years. Reherniation doesn't necessarily mean reoperation. Some are managed non-surgically, but it is a real risk, and patients deserve to know it. Let's discuss now what surgery cannot fix. Surgery for lumbar disc herniation is a decompression procedure. It removes the material compressing the nerve. What it cannot do is reverse any nerve damage that has already occurred, restore a disc that has lost height, and structural integrity, or eliminate the underlying degenerative process that led to the herniation in the first place. A patient who has had significant nerve compression for an extended period of time may have residual numbness or weakness after surgery that takes months to recover, or again, in some cases, does not fully recover. The nerve heals on its own timeline. Surgery just creates the conditions for that healing by removing the compression of the nerve. What this means for you is that surgery is most effective when it's timely, when the indication is very clear, and when expectations are calibrated to what the operation is actually designed to do, which is decompress the nerve and relieve the leg pain. When those conditions are met, the evidence is strong and the outcomes are generally very good. Let me bring the full series together. A lumbar disc herniation is not one thing, and it doesn't have one trajectory. Some herniations resorb, some respond completely to conservative care, some require surgery, and the path from diagnosis to the right treatment is different for every patient, because the herniation type, the nerve root involved, the duration of the symptoms, and the patient's goals all shape the decision. What this series has given you is the framework to understand that decision, the anatomy behind your diagnosis, the symptoms that tell us which nerve is affected, the treatment options, and what the evidence supports for each. And now the honest picture of what surgery involves when it becomes a right call. Surgery for lumbar disc herniation, when it's indicated, is one of the most successful procedures in elective spine surgery. The evidence is real, the relief is real, and for the right patient, the decision to move forward is the right decision. If you have been through conservative care and you're still dealing with significant symptoms, your leg pain is limiting your life, your neurologic exams showing changes, if you've been told surgery is the recommendation and you want a fresh evaluation, I see patients at Twin Cities Spine Center in Minneapolis, and you can request a consultation through the link in the description. If this series helped you understand your diagnosis and feel more equipped to navigate it, share it with someone who just got an MRI report and doesn't know what it means. That's exactly who these 4 videos were built for. Thank you for watching the whole series. I'm Dr. Omar Ramos. I'll see you in the next one.